Board of Health will come to order. We have any comment from the public this morning, online or here in the office? Jeff, I see you're with us.
Good morning, board chairman and board members. My name is Jeff Patterson and I live in the 5th Ward in Billings. Just an average guy and I really don't know science too much. But I do remember when I was in elementary school, I got to see those pictures of you had chimpanzees and then you had apes and then you had mandrills. Then we evolved into humans and the difference between us and animals is we got a brain upstairs. And I always liked that picture. Recently when I was buying some farm fresh eggs and some raw milk, I was talking with the farmer. I said, "You're a farmer?" And he said, Yeah. I said, "Great." I said, "You got cows?" "Yeah." "You got pigs?" "Yeah." "You got chickens?" "Yeah." I said to him, "You treat them with ivermectin for parasites?" He said, "Yeah." "How about you? Treat yourself?" He looked at me with big eyes and he says, "Oh, I never thought about it." So I'm thinking to myself, well, if we came from apes and we treat our animals, but we got a brain, why don't we treat ourselves? So my point is, I know that this board can't approve using a medicine that's not approved. But what I can say is this board has a voice in Montana. And there's 5 states right now where you can buy ivermectin over the counter. There's a number of different states that have it in their legislatures. And I'm not even going to go into what I think that ivermectin can cure because, those are conspiracy theories. But I think that it's important that we remember, like I did when I was a kid, that we all are animals at our basic core. So if we're all animals and we treat our animals with ivermectin, maybe we should treat ourselves too. Anyways, thank you very much for your time. I appreciate it.
Thanks, Jeff. Any other comment, public comment from the board this morning? Hearing none. First item is to approve last month's meeting minutes.
So moved.
Second. All in favor?
Aye.
Opposed? Aye. Motion passed. Yeah, we're ready for your report.
If only I were. I'm trying to find the board packet. It's not coming. All right. Thanks. Sorry again. So first and foremost, a couple off the docket items here. I wanted to take a minute and invite folks April 14th and 15th here in Billings at the Hotel Conference Center this year, right? Not downtown, the Confluence.
Yeah, it's at the Billings Conference Center.
Conference Center.
Yeah.
So it used to be downtown. It's down at the Billings Hotel Conference Center this year. Confluence Public Health Meeting, annual meeting. Public health leaders from across the state, and all are welcome. So take a look at that opportunity. But there is a specific opportunity for Board of Health training. And so April 14th and 15th, the training starts at 10:30 and the morning goes till all day on the 14th until noon on the 15th. It's $230. I would love to support 2. That's one more in addition to our chair who's interested in attending. So please let Carrie Ludwig know if you're interested in that opportunity or are able to go yourself as well. Then we also had a great win last week. It was match week and we matched our MFMR class of 2029.
Congratulations, man.
8 residents, great work by the residency team. Always a hard, drawn out process with many virtual interviews. We keep trying to crack the nut on getting resident candidates to show up and come in person to interview, particularly here in Billings. But good news, we ended up with 8 total residents in the class, as well as 2 into our rural Miles City track. 2 great gals will be joining us in Miles City. And we also have a second-year resident who will be moving into our program from another program. So pretty good match week for the team. And then I was in Butte yesterday and the day before for meetings with Montana Health Plus and the Montana Primary Care Association. And during those meetings, we had several board meetings. They have their annual conference. They have a IT tabletop training where they go through a cyber disaster. Our IT team is there on site, along with Lauren Brown from the clinic, enjoying that conference. But I was there more to interview 2 finalists for the new MPCA, Primary Care Association CEO position. Cindy Sturgar has announced her retirement. And so we had 2 great finalists join us for interviews, and we should be making a decision here soon. So
Are they Montanans?
they are both Montana.
Okay.
Yeah, that is good. That is good. So there's all the off the cuff updates. I guess as you could see this morning, the Colonial is no longer. There's a little. The contractor began work last Monday on the 23rd this Monday, the 23rd. Feels like I've been gone a week already. I just went to Butte. It's a time machine. But they started on Monday, had the main Colonial apartments down by Monday evening, and then began work on the rest of the site. So we are moving on from that chapter of the saga and rewriting a new story on the corner of 27th.
So just gonna gravel top that?
For now, yeah. There's worries that it'll be a parking lot and a car wash and a casino. I was
Casino combo.
I was thinking a car wash, casino, vape store combo so that we could raise money for the future of the building, and self-storage maybe. But no, for the reality and the long term for now, while we build out the Community Resiliency Center, that will be a vacant corner for us to envision the future. And so the future really is a center for community resilience, turning a symbol of trauma into a symbol of strength and support for the South Side. And so that is the way in which we'll be moving. And hopefully we'll have some future plans and be able to envision what that could look like outside of my AI model, but more realistically on what we can put there. So more to come. We celebrated our very own 40 under 40. Shay Saunders, Dr. Shay, a family medicine physician and an MFMR grad who stayed with us after graduation last year. She's currently program faculty for the residency. Selfishly, she's my children's physician, and just a good old great doc. And we're proud of her, as well as we're proud of Casey Jansma, our physician assistant and the lead provider down in Bridger and Joliet, who we received some good news. Hopefully will be coming back to us full time again in Bridger and Joliet. So great to have those 2 ladies with us. Speaking of Joliet, they recently approved the purchase of that piece of property we've been talking about for so long, the corridor there on 212, the grassy area. And we'll be moving forward, hopefully with them, to survey that property and review the feasibility of placing a new Joliet clinic with some expanded services in that location. We also did put in an application for congressionally directed spending with Congress to receive monies for that rural health expansion project. And so hopefully If Congress can get their stuff together, we may receive some funding for a new clinic in Joliet. That's a longer term process. We had a great successful ribbon cutting for our Montana Rescue Mission Healthcare for the Homeless Clinic and have seen many new patients as a result, providing access to care on the campus of MRM now. So that's been a continuing great partnership that continues to grow. And during this month's board meeting later today, we'll get some board education on all things 340B and how that program is impacting us currently and into the future. But I also wanted to continue to make you aware of the Community Health Center Drug Pricing Protection Act. They're going to have to come up with an acronym for that. 7391 out of the House and Washington. And General Jack Bergman and Jake Auchincloss introduced that into the House. It's a waiting committee with Energy and Commerce. And that bill seeks to protect and follow the 340B legislation and regulation as it was written to protect community health centers within that program.
So John, backing up to the MRM.
Yes.
I know that they let 2 people go this week. Does that have any impact on?
That, no, not to my knowledge, no. I believe that was tied to shelter operations. Yeah. So no, we continue to have good positive working with. Where was I? This month, we also had the opportunity to present at Leadership Billings on all things RiverStone Health. So always a good opportunity to get out in front of our community and talk about all the things that RiverStone Health does that people in Yellowstone County don't realize we do. And good news for our dental program too. Our dental resident, Dr. Sima Miranda, will be staying with us for 1 more year in his advanced education and general dentistry residency. We continue recruitment for our APP residency, and we kicked off this last week a year-long effort to strengthen our internal leadership team. So our cross directors and mid-level managers are going to engage in a year-long leadership development institute with Sound Mind Leadership to improve their own leadership skills and invest in our team. So just 1 more way that we're able to invest in our workforce and strengthen the culture that we hold so dear here at RiverStone. United We Read was a resounding success. Well, Eric and I will be back over at United Way today to talk to their community leaders luncheon. They've asked me to provide the keynote, so I've obliged. And then our public health efforts to close the regulatory gap in food code, enforce Montana law equally as it relates to food additives and ingredients, and FDA regulations on the subject, maintain a high legislative and public interest, because at the end of this month, March 31st, the Yellowstone County Attorney's deadline expires for the removal of those products from licensed food establishments. And so we will take anybody that's not in compliance by the 31st and submit them to the Yellowstone County Attorney's Office for potential injunctive relief. It should be pretty straightforward. Montana law is Montana law. FDA regulations are FDA regulations, and we need to comply with that. So time will tell. And then pictured below, we've got the pan-respiratory dashboard. You can see while flu sort of takes a break this season as warmer weather hits, RSV is not. RSV illness is remaining high across Montana. We recently recommended the extension of pediatric RSV immunizations across the state with DPHHS, and we are currently seeing a spike in RSV throughout our state. So monitoring that closely. Any additional questions?
Questions for John? I would say that trying to remember the first time I discussed Colonial with anybody here. Came up at Finance Committee probably 2 years ago. Spencer and I left finance, got in the elevator, and we were alone, and he looked at me and he said, "What do you think?" I said, "Boy, if we could take it out, that would be great." He agreed. The conversation lasted all the way to my pickup truck. But a lot of people have been involved here in good work. That will make this campus so much safer, just so much better.
For sure, for sure. And in our city, in our county, for sure. It was a nexus of a lot of problems, and I agree with my public critic from Butte that, it was a very historic building 20, 30, 40 years ago. But we let it fall into disrepair, and we put up with a bad landlord who created a tainted legacy for the building. And there was no other option but to move forward with the demolition and move forward with something new in that space.
In my committee that was called Save the Colonial was disbanding.
All right. Never sure.
Okay, Megan, you're up.
I think you have my report. Just to quickly go over a couple of things, you have the update on sort of where we're at with staffing. Our biggest struggle continues to be with our medical assistants, and that's continues to limit the number of providers that we're able to staff at one time. We're really looking on trying to be creative and push more towards telehealth. It's hard. Telehealth has been a little challenging for some of our patient population, both because many of our patients that are close enough to us would rather come in and see their provider face to face. And those of our patients that live in more rural communities that are outside of Billings, many of them are still limited by adequate internet and cell service, giving them reliable connection. But we're continuing to work on that and continuing to figure out how to get more people comfortable with that type of intervention, which would decrease our load on our medical assistants. We covered Match Week. I spent some time talking about the workforce development pipeline that John has also talked about. We're really focusing on the APP residency, but also looking at how do we build any training pipeline, and then also trying to address the behavioral health provider shortage that we're also seeing here and across the state. We still have several open positions, and we actually have more positions that we probably could use, but we haven't been able to fill some of our open positions that we have. So we're continuing to figure out how we can be creative to provide those services. I think the other important thing that I would like to note is that next month is Child Abuse Prevention Month. So the CAC has done some work in the community to try and create some awareness. We know 1 in 7 children have experienced abuse or neglect in the last year in our country. The majority of that is neglect. That is really believed to be way underreported from what is actually happening. We know that throughout the course of childhood, 1 in 4 girls experience sexual abuse and 1 in 13 boys experience sexual abuse. So this is a major community issue that we often don't address as well as I think we should. Anyway, but we will be there. We've gotten some coffee shops that are engaged in supporting Child Abuse Prevention Month. Proof Donuts is going to be creating some special items on their menu to support child abuse. We have the Best Beginnings Coalition working with some of the daycares to be able to spread awareness, and we'll be sending out awareness emails, and have the blue pinwheels. So when you see the blue pinwheels in town, that's what that's for next month. And other than that, I think everything else is in my report. We're very excited about our residents. I just want to reiterate that. We have some good folks coming to join us. We have some good folks who are leaving us. Probably next month, we'll give you the update of where people are going and a little more details about who's coming.
That was a lot more successful this year than previous years, right?
Pretty similar.
Was it?
Yeah, pretty similar. We need to do some work. We have not, the last couple of years, we've matched people, but the majority of the matches that we have made have been SOAP process, which is not the initial match. This is a trend that we've seen more recently with our program here. When I first came here, we were, the first 5, this has really been over the last 5 or 6 years that we really have struggled. I think it's for a variety of reasons. I think that Dr. Brand and the residency team is sort of doing a lot to try and figure out how do we improve our efforts in getting people here. I think a lot of it is people aren't coming to Billings for their interviews. It's expensive to get here. I think that part of it has to do with just a declining number of people who are going into family medicine in general. And we're seeing that impact across the country in family medicine residency programs. I think that, we can talk more about other potential contributors. We look every year, we send out a post-match survey. And so we send out a survey to all of the candidates that we offered placements in the original match who didn't come here to find out why they chose to go to other places. So sometimes we have information back in that.
So Megan, I see PA Caruso came back, and was that for personal reasons, or did you give him some type of package that enticed him back, or
It
what?
was personal. We see that a lot here, actually. We've had a number of providers who have left here to go to, we don't pay as well as other places do in town. We really struggle with market rates for our medical providers, like by a lot. And we have seen providers leave and go to other places. And sometimes they end up coming back to us because of all of the other things. Not that means let's continue to underpay our staff and our providers. That's not a winning strategy. But I think it does speak to the culture of the organization and the mission of what we do, that people are willing to come back and take a pay cut to be able to work in our organization and with our patient population. So
I was hoping you had found the magic pill and you could tell me what it was. So I could start using.
I think the magic pill is us, right? The magic pill is what we do, is what we do, and the impact that we have. And I think a lot of people are really committed. The people who choose to work here are really committed to that. And I think, particularly, I know Chris, and speaking a little bit to him personally, he went to go do urgent care, where, you definitely get paid more. And what he ultimately said was, in urgent care, I was seeing our patients that really needed preventative and primary care, and I'm now seeing them in the urgent care setting. And I couldn't do the things that I knew would really impact their lives. And I kept trying to send them back to RiverStone, and would send them back to RiverStone. And I just realized that that's what I wanted to do, was I really want to be on that side of taking care of these patients. So we're happy to have him. We're happy to have him back.
The medical assistant shortage, is that a supply shortage, not enough of them in the market?
Yeah, our pay gap with our MAs it's less. We just recently have looked at that. We're still a little, we're a little less. We're a little less than our competitors are, but not as much of a gap. But yeah, we just are not getting, we just do not have a lot of applicants who are even applying. And that's why I think really looking at, do we look at developing an MA training program? And we're even working with, at the state level and at the, city level, at how do we start that in high school? How do we help, work with high school students who are interested in at least starting this as an entry level career, and how can we help to support that so that they can graduate high school fairly quickly, step into a job where they have a certification, and then hopefully be able to use that as a ladder. Or for people who decide that that's, what they want to do for the rest of their career, they have that. Right?
How long is a typical MA program?
Most MA programs, most MA certification programs are around 9 months to a year. And
Okay.
there's, and there is, and so we're looking at how can we support the hands-on training here, and then potentially use like some online training for the didactic, portion of that, so that we can get them through. So, because it's quite expensive, and that's the other challenge, is that the MA certification programs are really pricey for someone who is not making, barely making minimum wage, and is going to come out making entry level salary.
To make them aware of the opportunity.
Yes.
In high school and starting to think of what they're going to do.
Absolutely.
Makes sense.
And we did just hire, luckily for us, one charter program closed here in town. Their MA training program coordinator went to work for one of the other facilities, and now she's come to work for us. So we're building that skill set to be able to build that capacity internal to train them. And it's not even necessarily a lack of applicants for the MA's role. It's a lack of qualified applicants. And in Montana, you don't have to have an MA certification to be a medical assistant. You can apply for medical assistant as long as you have a high school diploma. And so trying to build the qualified applicant pool, or the high potential applicant pool, where we can bring you in and we can train you to build that workforce pipeline. It's something that I'm going to meet with Commissioner Swanson again and DLI later this afternoon to talk about. It's the Rural Health Transformation Program funding in workforce. And it's something that we've had lots of internal conversations on. How do we continue to build our own?
Well, isn't that one of the programs Dr. Garcia is trying to work on in high
Yes.
school?
Yes, yeah. So working with SD2, trying to say, hey, within this new health professions high school program, let's build out some of these tracks, and then bringing DLI into that, let's make them available for credit and available for apprenticeships.
Thanks. Any other questions or comments for Megan? Hearing none. Spencer and Shanna, you're up.
Yeah, you want to start us off?
Absolutely. All right, in the packet we have January financial statements. I'll start with the more graphical pictures and go through highlights on there, and then talk through a few of the things that we talked about in our finance committee meeting. So in the month of January, we ended with cash of about 15 million. For context, that's an increase of 3.8 million from January of 2025. Of this balance, about 12 million of that is unrestricted. If we're looking at our days cash on hand metric that we've been following all year, we ended January at 77.59 days. And to put that in context, it's an increase of 32.16 days, or from 45.43 days where we were at in January of 2025. We ended the month of January with a bottom line of 451,000 positive. Just to put some context around that, really that's being driven, like we've talked about most of the fiscal year, by our wages and benefits variance. When we look at where our wages and benefits variance was for the month of January, we were under budget about $250,000. Year to date, our bottom line is about 2.4 million. And of that, about million of that is for the wages and benefits line item, so really driving that bottom line organizationally through this fiscal year. I did include one more graph within these financial statements for the month of January, kind of a preview to some of the information we'll be receiving from Marcus related to 340B. And this really just contains some information on the Medicare price negotiation financial impact that we are seeing for that. We obviously knew about this as we were budgeting for this fiscal year, and so we took this into account, but I think it just kind of puts it in context when you look at the pictures of it. So I'm looking at the third page of the graphs where the header is 340B pharmacy Medicare price negotiation financial impact. And so you can see on the top left shows our reimbursement for the last 12 rolling months for those drugs that were sold this calendar year. And you'll see a decrease from December. We were at about $138,000 in reimbursement down to about $67,000. So just shows the impact of that. And really on the top right hand shows the number of prescriptions. So no change really in volume related to that, just the change in reimbursement. We will again see that coming in January of 27. The impact in January or in 2027, we expect that to be about $500,000 impact. So pretty significant impacts to us overall. Again, like I said, we budgeted around it this fiscal year and we'll budget around it next fiscal year, but I think it shows the volume of that impact. The other thing, any questions on that? The other thing that we discussed during our financial committee meeting this month was we had put out a RFP for our audit services within the last couple of months, and we had 3 firms respond to that, which was wonderful. We had Pinion, which is our current auditor, previously Anderson Zillion, Bailey, and Whipsley all respond. We took those through a scoring recommendation and really came up with some high points for each one of those firms. Bailey had a strong alignment with governmental and healthcare auditing, and they had a pretty competitive pricing structure. Whipsley had significant national scale and they beefed up that security within their proposal. And ultimately, as we reviewed these internally with the finance, looking at Pinion, they really had the greatest continuity and institutional knowledge. And as we discussed that and talked through kind of the impact of that, ultimately the decision was to recommend sticking with Pinion really based on the lowest transition risk with our existing relationship with the auditors. Anything else?
Yeah, so maybe just to add on that, from a financial standpoint, all of the audit proposals were within the same ballpark. Was there, none of them really stood out as fiscally as a better choice, and I think ultimately the decision was to go continue opinions.
They're all 1 year.
It's
3 years.
3 years.
That'll help us continue with the same audit partner and audit manager, and so it just makes things almost their overall. Maybe I don't know that I have much to add other than to say that the organization's fiscally sound. We continue to make cash gathering a priority. So it's nice to see that we saw a small decrease in cash this in January, but that's just kind of part of the routine normal flow of cash. The other thing I was going to point out, we talked about this in our committee on last week, is that the Medicaid reimbursement still remains to be. I mean, if you're looking kind of pick nits a little bit, Medicaid reimbursement is still lower than what we forecasted, and still kind of becomes a problem. Not a huge problem, but just something that we need to keep our eye on. And that the second page of graphs that you see, I think that's it talks about how our net patient services revenue is down from budget, but our overall revenue generating patient encounters is up. So that just illustrates just the reimbursement levels aren't keeping pace with the number of visits. So fortunately, we're doing well. The other thing, there's not a graph in the package, but we talked about this during our committee, was we talked a little bit about staffing. And I think when I look at the graph that they provided us, in September of last year, we were at 315. And then in February, we're at 334. So it's just so while we're not exactly where we want to be, we're starting to see a steady increase in hirings and staffing up to kind of support the staff. So.
And Spencer, I would say that the Medicaid piece is not specific to you. I sat on the board of Bridgemont. I mean, community mental health partners come to us as the Board of County Commissioners, and Medicaid is just fighting everybody.
When we came out of COVID, the state was doing, what did they call it, John? Redetermination?
Yes.
Yes,
If, where has everything stabilized? How many Medicaid lives are there in the state? Does anybody know?
So it's stabilized for now. Don't have the number off the top of my head.
I can look it up.
It's decreased dramatically, and as of July 1st, even though DPHHS reported they only have about half the positions filled that they're going to need to implement Medicaid work requirements and the other provisions from HR1 federally will impact our Medicaid program. The department has said they're moving forward, not looking back, and implementing all of the work requirement issues as of July 1st. And so that will definitely have an impact. They don't have the adequate staffing to manage the, again, more redeterminations that we're going to see. And so we will be in a similar situation, but not as dire. It will most likely be less individuals impacted this go round. One, because they're going to do it on a rolling cycle based on when patients enrolled rather than pull everybody off at once. And two, because the majority of folks on Medicaid are working. And there is this misnomer and misfact that they're not, and that they're just sucking up government benefits because they want to stay home. That is not the case in Montana. The majority of our Medicaid enrollees are working and have jobs. DLI is working, Commissioner Swanson is working to create opportunities for job training and including volunteering at a local community health center, volunteer engagement on our community health center board, other opportunities that will count towards meeting those work requirements for Medicaid enrollees. And so we're going to continue to work with them to keep folks on the rolls correctly, make sure that enrollees are enrolled if they're working and meet all the requirements of the program.
Do we have any rough estimates of what percentage of Medicaid enrollees are working?
88 to 95%.
Fantastic.
I think there's a rough estimate of only 10% that are not, and may meet the requirements through some other program. The other opportunity that the state has yet to figure out how to manage are our seasonal employees. So seasonal employees within our tourism industry and outdoor industry, think guides, think wildland firefighters, folks that are employed for a certain number of months a year and then not. We don't have a good way to account for those job types within the system. And so there's a lot of conversations happening now between now and July of how do we account for all of those job roles and make sure everybody gets credit for working. There is a hold harmless agreement that'll take us through the last 6 months of 2025, or 2026 and into 27. One of the things that we are all asking, that healthcare is asking of the department, is to extend that hold harmless agreement. State does not have to implement work requirements until the end of 2027. But we are running full speed into the brick wall, and we're going to knock it down because we can, and we want to be first. And that will have consequences.
Another thing to remember, Michael, is public disability insurance is handled through Medicaid. Some small percentage, 5 to 10% of the Medicaid beneficiaries, it's where they get their disability coverage. Disabled people, that's where they get their health care. If they're federally disabled, unable to work, Medicaid does not cover that. So they get their health insurance through Medicaid.
It helps me to hear some numbers
Sure.
when people come and criticize and suggest there should be work, and they have real numbers to throw at them.
Vast majority of Medicaid beneficiaries are working.
We'll bring some better data to the policy committee next month and to the board next month.
And the challenges is they're also very mobile, they're moving frequently, job to job and from their residences. So keeping track of them is a challenge, keeping them enrolled is a challenge.
Yeah, allegedly, letters to beneficiaries went out last year or last month, or sorry, last week. But I haven't seen one of those letters yet, and we should try to get one of those from the clinic.
Only heard anecdotally.
Yeah.
Yeah. And Montana Healthcare Foundation data is about 20% of our population is on Medicaid. So that's roughly 230,000 people. And in Yellowstone County, we skew a little higher, 26%. And exactly what John said, when you factor in working people who are caretakers for people who are in school, it's up in the 80% of people that are on Medicaid.
Any other comments or questions on the finance committee report? Can I get a motion to accept the meeting notes and the financial statements?
So, second.
All in favor? Those same sign. Policy committee, Brent,
We did not meet. Report.
excellent report.
Very brief. Meet again April 7th.
Dr. Tapia, safety and quality.
Yes, sir. Actually, I was on the road between Flagstaff and Page and listened in on the meeting, but Dr. Dorr was there and has graciously agreed to make the report today. Dr. Dorr.
Okay, thank you, Lionel. First order of business was we had recommendations from Dr. Littlefield and John to grant privileges to Dr. Thomas James for hospice and palliative care. The committee unanimously supported that and brings it to the board for approval. So do we need a motion for that?
We will. Would you like it now?
Please.
Can we have a motion and a second?
Second.
All in favor? Any discussion? All in favor? Opposed, same sign.
He's in an outstanding position in Billings for years. The rest of the meeting was devoted to AI in public health. And Bob Janicek has graciously agreed to give us a summary, which I know he can do much better than I can.
So good morning, all. As you're aware, we changed the format of our safety and quality meetings to take specific subjects and then have each of our service lines come in and discuss how they are impacted by those particular subjects. Most recently, to Dr. Dorr's point, is AI. And we had in February, home care and hospice came in, and this last month was public health. Coming up in April will be the clinic. So we'll get that encapsulated view. And there's also been some discussion that at some point, the entire board might want to hear some of the materials that we have been discussing in committee. So with that, we did meet with public health, and their perspective was different, but really interesting. We talked a little bit about they are just dipping their toe into AI. So they're using some of the frequently used tools within the Microsoft suite for doing some research, compilation of materials, but really haven't fully embraced it. They're kind of in the, I believe, Kristen said, they're in the watch and wait mode to see what other public health departments are using, how this gets adopted on a broader scale. That said, they spent a good deal of time talking about the environmental impacts of AI. So we all know the processing, the
the lift for labor force, et cetera. But we talked a little bit about, what does it mean from the power perspective or the water for cooling perspective, or taking up some of our rural settings for big buildings that house computer resources. And that discussion was very good. Again, just making us aware that there's more impact than just the workforce multiplier. And we talked about noise. We talked about all of these things. So we wrapped up the meeting with a little tour. Dr. Dorr, Michael, and myself went and looked at our computer room, which is very small in scale compared to what we're talking about from the AI data centers. But they were able to get a look at what's in there relative to independent cooling for all of that equipment, the hum, the buzz, the noise, the power draw, all of those things. And we certainly wouldn't want to give them up, but they did make mention that they had not been in our computer room and they've been on the board a long time. So I'm just going to extend that offer to any of you that want to take a look at that, because we have invested in that historically fairly heavily. But we also believe that the future lies in the cloud foundry, which means moving all of that heavy infrastructure into a data center somewhere else. So I thought it was a really good meeting. And being the tech guy, I don't always think about the environmental pieces. They're there, but kind of in the back. And so I think the public health team did a very nice job. Kristen was pinch hitting for Melissa, and between the two of them, the materials were solid. So Dr. Dorr, Michael, if I missed anything, feel free.
The thing I was really impressed with in the data was that a data center uses more water than 2 golf courses. Michael.
I expected I didn't want to call it even a center. I expected a little closet where we have all the materials for a data center. And I was enormously surprised and impressed at the extent and complexity of it. And I would invite anyone who wants to take just the scope of what we have here is enormous. And scaling up to a large org, I would advise you take up Bob's offer and take a little look at what is here. And it also helps when we see on an annual basis how much we're spending on equipment and fixes and those switches that I always thought was a wall switch. It helps justify the budget, the expenses of the operation.
Where is it located?
Bob, could you maybe briefly talk a little bit about the committee that reviews the usage of AI?
Sure, be glad to. So one of the things that sits on top of all things AI within health is our AI governance committee. And it is made up of representation from across our teams, specifically those individuals that have interest in AI and some experience with it. And we meet and we talk about use cases for AI, what software is available that has components of AI. And as a committee, we make the decision about whether we're going to approve the use of that capability or not. Because we want to make sure that as an organization, we're being progressive in adopting those tools, but we also know that there is significant risk associated with AI. So that committee meets every other month. We were meeting monthly, but as you can imagine, it was just hard to get that group together. A lot of our representation comes from the clinic side. And so, roping in, for example, Dr. Brand to come in and talk about AI in the clinic gets a little bit difficult. So we meet every other month and those use cases come forward and we talk about them. That group also helps us when we discuss locking things down. So for example, if we decide to lock our firewalls down, to where you can't access specific AI that's not been approved. They help us to, one, approve that. Two, how do we communicate that? And three, understand what the impacts of doing so. So that is a very important component of our AI governance. On top of that, we have AI embedded into everything from our notice of patient privacy to other policies and workflows that exist across public health, the clinic, home care, and hospice, to ensure that we are closing the loops relative to people understanding we are using it and what we are using it for. And if they would choose not to have us use it, we have a process by which they can say, I don't want your computers listening to me talk. So that's kind of it in a high level nutshell.
Perfect. Thank you.
For comments or questions for the safety committee? Hearing none, can I get a motion and a second to accept the meeting notes?
So move.
All in favor? Opposed, same
Aye.
sign. Accepted.
Did we accept the financial reports?
Yes.
Okay.
Any old business to come before the board this morning? How about a 340B drug price programming update?
This is gonna be here at 8. He's getting the pharmacy open right now. I can either pinch it for him, or if you've got other items. You can,
Pinch hit.
Pinch it. The chair has no other items.
okay.
We'll get it loaded slowly too, Eric.
No worries. You're getting the B team here, so bear with.
Is there a way to share the screen?
You're working on that. Yep.
All right. Excellent.
Oh, not whiteboard. Yeah, just by his name.
All
Looks
right.
good.
Can y'all see it online there? Great. Okay, so this is gonna be a pretty high level overview because people go to 340B University and spend a week learning how to operate this system within a health center. But essentially, the background, it was established in 1992. It requires pharmaceutical manufacturers to provide medication at significantly reduced prices to eligible covered entities. Basically, an eligible covered entity is a nonprofit community benefit hospital or a community health center. Whoop.
He says he's gonna be coming over.
Okay, cool. Participation in the 340B program is mandatory for all manufacturers who participate in Medicare and Medicaid. So the way it works, medications are purchased under the 340B program, and they must be used for patients of the covered entity. So in our case, our pharmacy serves people who are both our clients and not our clients. And so we have to make sure that the medications that we use for 340B are used only for our clients. And then our non-340B medications can be used for people who aren't clients of our city or of our clinics. I'm going to introduce Marcus because he's the expert. He must have run over here. That was fast.
Yeah.
So we just got through the first slide. And so this is where we're at.
Okay, yeah, so
Pharmacy Director Marcus.
nice to meet you all. So I bolded that last statement just because it highlights the whole reason why we do what we do and why it's strange that we're coming under scrutiny. So next slide is good.
Perfect time.
So do you have to,
Yes.
do you keep information separate on patient versus company? How do you know you're giving the right prescription, or the right drug to the right person? Does that question make sense?
It's like, how do we know if it's a clinic patient that we're receiving the prescription from?
Yeah.
So we have access to the medical chart, and so we can tell usually from where the prescription comes from. It has our address and everything on it, so we kind of know the providers that work here.
Okay.
So if it's a provider that works here, most likely it's a patient they saw here in the clinic. So it's usually pretty easy. Sometimes get a little tricky if it's a resident or somebody from the hospital that's practicing out there, and then we have to just make sure that we have an updated resident list and that we're looking at
So
that.
it's tied to the provider.
Yeah.
It was on a previous slide, but I think you may have just answered it. We go. The money, oh,
That's.
never mind. I'll try to.
Go back
Sorry,
instead of forward.
It's going,
That the revenue has to be used for uninsured or limited income
there we
patients.
go. It was going the wrong way for some reason.
Yeah. So the point of that is just that the money that we're generating from this program, we're not pocketing it for our profit and to increase the CEO salary and all of those kind of things that would be inappropriate. We're actually using it to serve patients.
The whole goal of the 340B program, why it exists and why community health centers were codified into the program was to be a care extender, was to open up the opportunity to increase access to care for the uninsured, for the underinsured, for folks that are living on the margins who don't have access to health care. The 340B revenue generated from that program keeps our clinic doors open, keeps the lights on, allows us to provide staffing, hire more nurses, hire more physicians to take care of people, not to provide any of the money into, future planning or other, like it's my salary or any other bonuses, things like that. It goes direct to patient care.
And as you can see, I mean, it's no surprise to all of you, I'm sure, that there's a lot of people that fall into this category in our country. So, thank you. So I don't know all the reasons why the program has existed for this long, and really just in the last year or two, it's coming under a lot of congressional scrutiny. We can postulate on the reasons for that, but basically the argument is that the program in general lacks appropriate oversight, and that covered entities are abusing the program and not using the funds where they should be.
And there have been cases of that across the country. There have been 0 cases of that in Montana. And there have been only 1 case of abuse by a community health center somewhere in the South.
So it's not community health centers that are the problem with this. It's other entities.
I pushed the button, Marcus, I promise.
Okay.
How do you make sure the money is only being used for its intended purpose?
Well, we keep it separated, every program within the organization. And so anything received from 340B is quoted separately within the 340B project code.
There we go.
There it is. Well, it's.
All right. So I just included this slide because it kind of highlights what's out there in the media right now about 340B. So this came from a blog site of pharma. I don't have to really explain what pharma is really. You guys can all imagine it's a conglomeration of different major drug manufacturers who are the drivers really behind the scrutiny on 340B. Basically claiming that providers in 340B programs are charging patients and not using the funds where they should, which is a kind of a gross overstatement.
So that's a quote, who's being quoted there? New York Times, or is it a?
That's a quote from the industry. That's an industry quote from pharma, which is the Research and Manufacturers Professional Association.
Yeah. So how it's causing strain on us, because we are technically a contract pharmacy for the clinic, the manufacturers are now requiring any contract pharmacy to submit all of their claims data to them through a third party. So that we basically I have to download once a week right now, probably going to have to start doing it almost daily very soon, and letting the pharmacy manufacturers know exactly what we're dispensing, how much we're dispensing of it, what we're getting reimbursed really for it. And that's really the problem, is that manufacturers have been trying to get their hands on this data for a long time and to figure out ways that they can have that data. They're saying it's for oversight. Maybe part of that is true. We kind of assume that maybe it's to negotiate different contracts with pharmacy benefits managers and figure out how to reduce reimbursement rates. That's speculation, but none of it is really good for community health centers as far as having the manufacturers access to that information. Also, a lot of the manufacturers are limiting entities to having only one single contract pharmacy. So that comes back to the whole point of the 340B program, which is access to care. This is another barrier to that, to say that RiverStone could have only one contract pharmacy designated where all of your patients have to come to this particular pharmacy, which has its own problems depending on where patients live, and definitely creates barriers. Another thing is that they have introduced plans for a 340B rebate model. Basically, what that means is right now we can purchase the medications at the discounted 340B price, and then we bill the insurance, and then the difference is our savings. The rebate model would mean that we would have to pay the full price for the drug, so not the discounted 340B price. The manufacturer would then get our data, review that claim, and then they would make a determination on whether they agree that that claim is 340B eligible, and then in an undetermined amount of time, send us back a rebate amount in an unknown amount. So you can see all the problems with that, and the strain that puts on our fiscal department and not knowing what we're going to be generating, whereas currently we have that information in real time. That was supposed to take effect this year. It didn't. The 11th hour, there was an injunction from a federal court that blocked the implementation of the program temporarily. It did allow for them to rewrite the language and reintroduce, which they have. And it is looking that it will go forward in the next year. So that is happening. There are some things going on to try to mitigate some of that impact. I'll mention that on the next slide. So yeah, so bottom line for us, the trend is towards ramping down on the revenue that we can generate from the 340B program. And we're seeing a lot of the hit of that already, not just in the direct cost of the medication and revenue there, but also in administrative costs and the time that it takes, like, for example, for me to do all of this oversight and monitoring and reporting, and it's taking me away from my ability to take care of patients, which is what I'm here for. So there's a pretty high cost for all of that in this time event. So every covered entity in the country is having to go through this right now, and the future is uncertain. There's just a lot of things that are up in the air right now. We don't really know how deep this is going to go. Both sides are filing litigation. There is some hope right now as far as the rebate model program goes, in that there's legislation that's being introduced that will exempt community health centers from the rebate model. Since logically, if we're not part of the problem, we shouldn't really have to go through the same scrutiny that other entities do. So that's some really forward, straight thinking, I think, but we'll see how that goes. It does seem to have quite a bit of support in that regard. Fortunately, community health centers are a fairly bipartisan thing, and there's a lot of agreement there. So hopefully it'll go that direction, but we're just kind of waiting and seeing what's going to happen for 2027.
That was the bill I mentioned that's in the House from Michigan and Massachusetts. And the other conversation we're having is how do we include critical access hospitals in rural communities within that bill as well? Because we don't just want to protect us, we want to make sure that our hospital partners are also on board. And critical access hospitals across Frontier, Montana also rely on this program to keep their doors open and serving communities. So we'll have much more on that.
Any other questions?
Is every drug that you buy have a 340B price to it, or is it just a limited number of drugs?
Most of them do. The amount that they're discounted varies greatly between different drugs. So the number of drugs out there that we can generate a lot of revenue from is less than the total number of drugs, obviously. But yeah, they do generally offer, because the manufacturers have to offer 340B pricing if they're going to participate in Medicaid and Medicare. That's going to include almost all of them. There are some specialty manufacturers that don't delve into 340B, but not very many.
I missed something, I'm sorry. Is the price of the 340B drugs to the client, is that something that we set or something that's told to us, the price for it?
So HRSA sets the maximum price that can be charged, and then the wholesalers can negotiate small differences. Yeah, they have to stay below that ceiling price. So the wholesalers can then offer it up to that ceiling price for us to purchase from them. And then we can pass those savings on to the patient.
This may be oversimplifying, but if I'm hearing it's the pharmaceutical manufacturers that are opposing this because it's taking away from their profits. Is that
Yes.
where this comes from?
Yes.
Yeah. They would love to limit the amount of drugs that they have to sell at the 340B price.
Yeah.
Yes.
It's a fair fight because they don't have much of a lobby for us to.
They aren't making any money, so.
Yeah, I think I mentioned last year that the National Association of Community Health Centers was, Marcus mentioned, I don't know why this came up now because 340B was like Fight Club. The first rule of Fight Club is you don't talk about it. First rule of 340B and with NAC started talking about it. NAC's new leadership thought that it would be appropriate to partner with pharma on a way that they could save 340B and save access to it, the program for community health centers, and it's completely backfired. And so here we are. Yeah. So I had a very good professional conversation with NAC's chief operating officer yesterday, who was in Butte for our primary care meeting. So she'll be taking lots of productive feedback back to DC with her. So that in a nutshell is why we're here. Thank you, Marcus.
Yes, thank you guys. Thank you. Appreciate it.
Shannon, you showed a chart of the 340B revenue decline. My recollection is that 340B is not a real money maker, but it covers its costs. We sell for very close to what we purchase. Right?
Actually, last fiscal year, it was about a couple $1 million. It was pretty significant. And so this year we budgeted a total of about $700,000 impact. That's a calendar year for 2026, the impact of these drugs. And then next year it'll be about $500,000.
Okay.
A little bit lesser each year on those drugs that are being selected, but still pretty significant impact.
Where I'm going is, I assume that our acquisition price has declined. We hope pretty similar to what the.
No, actually, there's an inverse relationship. So when the market price of a drug goes down, the 340B price goes up. Because the whole point, it was set up as a disincentive for pharmaceutical manufacturers to rapidly inflate the prices of their drugs.
Okay.
So the higher the drug cost, the lower the 340B cost. The lower the drug cost, the higher the 340B cost.
Right, let me ask it a different way. If I go out and buy, last year I'm buying a medicine for $100 per unit dose.
Mm-hmm.
And I would sell it to the patient for $110 a unit dose. This year I go out and buy it for $50 a unit dose. Right, this year I'm selling it to the patient for $50 a unit dose. I'm assuming my acquisition price has come down close to that $50 a unit dose.
So if you're uninsured, we give the 340B, we give the drugs to the patient at the 340B price plus a dispensing fee.
Right.
So it's the insurance companies where you make revenue from the 340B savings.
Yeah, I'm just making sure in my head that as we had to reduce our price, our cost, our price is still a function of what we're paying for the med. Plus that administration.
Yeah, we're just losing a lot of margin on it.
Yeah. Okay, thanks. Anything else to come before the board today? Michael?
Jim, with the chair's permission, may I have 6/8/15? Can I have 45 minutes about ivermectin? You can say no.
No. I do want to address two questions from the survey last month. One, there was a question on the patient portal and how many patients are enrolled in the portal. About 20%, about 2,800 patients are actively enrolled. And right now we have a current ongoing campaign to boost enrollment in our enhanced patient portal. So folks can get ready access to their electronic health record. And then the last question on the survey was about the future of the foundation. There is a future for our foundation. We need our foundation. And right now we're in internal current conversations about how do we restructure that foundation and what does that need to look like. And so I'll be presenting, we'll be communicating with the foundation board shortly to have a meeting, bring us together and talk about the internal structure, some opportunities for what that can look like, and how we move things forward there. But for now, we're covered internally with some great staff within our communications and marketing department. Carrie's monitoring communications for the foundation now too. Thank you very much. And we're continuing to move forward. The golf tournament continues to get planned and move forward. So we'll move forward with all of the plans and programs that we currently have in place and look forward to building something better.
Did we hire a new
in the
director?
future. We have not yet. We have not.
Okay,
So
we were close to getting one, but no, okay.
nope.
Like 5 minutes. Time.
Ask for 5 minutes.
I'm